So after discussing laryngoscopy, which is an important ENT diagnostic procedure, now let's move on to another procedure known as bronchoscopy or examination of the bronchi. Two types of bronchoscopy can be used. We have rigid bronchoscopy, in which rigid bronchoscope can be used, and then we have flexible fiber optic bronchoscopy. So main difference between the two is the type of bronchoscope that can be used for visualization of the bronchi. Rigid bronchoscopy. Indications for rigid is we have diagnostic indications to find out the cause for wheezing, hemoptysis, blood in the vomiting, hemoptysis, or unexplained cough persisting for more than 4 weeks. So if these are present, we should go for rigid bronchoscopy. So to find out the cause for wheezing, hemoptysis, unexplained cough persisting for more than 4 weeks. When X-ray chest shows atelectasis of a segment of lobe or entire lung, opacity localized to a segment or lobe of a lung, obstructive emphysema to exclude the foreign body, and hilar or mediastinal shadows. So all these are the indications for rigid bronchoscopy when the X-ray of the chest is performed and it has atelectasis, opacity, emphysema, or hilar or mediastinal shadow. We should go for rigid bronchoscopy to find out the cause of these conditions which are present. Vocal cord palsy is another indication for rigid bronchoscopy. Collection of bronchial secretion for culture and sensitivity test, acid-fast bacilli, fungus, and malignant cell. Therapeutic indications for the rigid bronchoscopy: removal of foreign body which can be present, removal of any secretions, mucus plug in case of head injury, chest trauma, thoracic or abdominal surgery, or comatose patient. So all these are the indication of rigid bronchoscopy. We have diagnostic indications for the diagnosis of different conditions when we are not sure, and for therapeutic reasons if there is some foreign body that access to the bronchi and is causing the bronchial obstruction and causing the respiratory or ventilation problems, we should remove that foreign body from the bronchi, and rigid bronchoscopy is used for the removal. Then we have other secretions or mucus plugs present. We should remove those by the rigid bronchoscopy. Anesthesia and position. Anesthesia, general anesthesia with no endotracheal tube or with only a small bore catheter. So that's the anesthesia. Usually general anesthesia is used. Topical surface anesthesia. Position is the same as for direct laryngoscopy. Head is elevated 10 to 15 centimeter. Neck is flexed at the chest, and then the head is extended. That's the position for laryngoscopy, and that's the position also used for bronchoscopy, rigid bronchoscopy. We have therapeutic indications, we have diagnostic indication, we have trachea, which is the windpipe. Trachea divides into right and left bronchi, and these right and left bronchi, right goes into right lung, left go into left lung, and they further branch into secondary bronchi, and then secondary bronchi further divided into tertiary or terminal bronchioles. So that's a bronchial tree. So trachea divides into right and left. So it's a little far portion. We need to go a little far, and that's done by bronchoscopy. Technique is direct method, or it can be done through laryngoscope. So laryngoscope is inserted and then bronchoscopy is performed through that, or it can be direct method. Details of the technique: rigid bronchoscopy for foreign body removal. This is the foreign body present in the right stem of the bronchus, foreign body. The bronchoscopy is done to remove this foreign body present in the bronchi. A piece of gauze or a dental guard placed on upper teeth. Proper sized bronchoscope, lubricated again with liquid paraffin or jelly, is inserted. Shaft in surgeon's right hand in a pen-like fashion. So in the pen-like fashion, the shaft of the bronchoscope is in the surgeon's right hand. Fingers of left hand used to retract upper lip and guide the bronchoscope. Tip of epiglottis is identified first. So the tip of epiglottis is first identified. Bronchoscope pass behind it, behind the tip of the epiglottis, and epiglottis lifted forward to expose the glottis. Bronchoscope now is rotated 90-degree clockwise so that its beveled tip is in axis of glottis to ease its entry into trachea. Once the trachea is entered, the bronchoscope is rotated back to the original position. That's the bronchoscope, that's esophagus, gullet, that's the trachea, right lung, and this is the left bronchus. So the details are it's inserted by elevating, passing behind the epiglottis, which is lifted forward. To aim is to open up the glottis so we can easily remove any foreign body that is present. Bronchoscope is gradually advanced. Entire tracheobronchial tree is examined. Axis of bronchoscope made to correspond with axis of the trachea and bronchi. To achieve this, the head and neck are flexed to the left when examining the right bronchial tree and vice versa. Opening of all segmental bronchi in both the lungs are examined in seriatim. So that's the main, bronchoscope is inserted, rigid bronchoscope can have diagnostic value, can have a therapeutic value. Different structures that come on the way can be examined, should be examined. The teeth and the lips should be protected by placing the gauze. Direct vision, right-angled and retrograde telescopes used for magnification and detailed examination. Biopsy of the lesion of suspicious area can be taken. Secretions can be collected for cytology or bacteriological examination. So once the bronchoscopy is performed, besides removing the foreign body, if there is any growth or any abnormality observed, we should biopsy that growth, or if there are any secretion present and there is any mucus present, we should remove that. So for a bacteriological and cytological examination, and to relieve the condition also. Post-operative care of the patient: keep patient in humid atmosphere, watch for any respiratory distress, laryngeal spasm or subglottic edema should be observed, can cause complications later on. Inspiratory stridor and suprasternal retraction indicate tracheostomy. Complications of bronchoscopy: injury to teeth and lips, hemorrhage from the biopsy site if biopsy is performed, hypoxia and cardiac arrest can also occur. Laryngeal edema can occur. Precautions during bronchoscopy which should be observed, precautions are important. Select proper size. Proper size according to patient age is very important. If the size is not correct, then procedure might not be correct. Do not force bronchoscope through closed glottis. Repeated removal and introduction of bronchoscope should be avoided. Procedure should not be prolonged beyond 20 minutes in infants and children. So it's a rapid procedure done within 20 minutes, should not extend more than 20 minutes in infants and children. Next, flexible fiber optic bronchoscopy, as the name shows, is flexible as compared to rigid bronchoscopy. That's the picture. This is the control section, eyepiece, channel port, suction tubing, light source. Then we have insertion tube, bending section. So the flexible bronchoscopy is done by a flexible fiber optic bronchoscope, and it's different, it's not rigid, and it's longer, extend in the lower area, and it's easy. Replaced rigid bronchoscopy. Provide magnification and better illumination. Smaller size of scope permits examination of subsegmental bronchi. So it's the smaller in size, it's flexible, easily passed through narrowed areas, so it has more access than the rigid bronchoscope. Easy to use in patients with neck or jaw abnormalities and injury. In rigid bronchoscope, that's a contraindication, should not be used for cervical spine injuries or abnormalities, but that's not the case for the flexible bronchoscopy. Perform under topical anesthesia. Useful for bedside examination of critically ill patients. Easily passed through endotracheal tube or tracheostomy opening. If we need the tracheostomy opening for the breathing problems, it can even go through the opening, and the endotracheal tube, it can easily pass through that. Suction biopsy channel helps to remove the secretions. Inspissated plugs of mucus. Even small foreign bodies can be removed. Now, the comparative advantages and disadvantages of flexible and rigid bronchoscopy. Anesthesia. Flexible is topical, rigid is general. That's one major difference. One can be performed under topical anesthesia, the other needs general anesthesia. Now, the route, nasal or through endotracheal tube, oral only. Structure seen, nasal cavity, undistorted view of supraglottic and glottic area, segmental and even subsegmental bronchi. Nose not seen, supraglottic area is difficult to evaluate. Only segmental bronchi can be reached. Bedside exam possible in flexible, not possible in rigid. Ventilation, poor control of ventilation, better control of ventilation. Foreign body removal, difficult, easy in rigid. Biopsy, only small piece can be taken, large pieces can be taken. Jaw and neck abnormality or injury is useful and is difficult procedure. Control of hemorrhage, difficult, better control. Cost of procedure, less, more. So there are some advantages and disadvantages of both procedures depending on our situations, circumstances, condition of the patient, even financial condition of the patient. We need to decide what type of procedure should be done. That was all about section 2. Thank you for watching sqadia.com.